cases that were submitted by members of our community. Eve, do you want to introduce our first speaker?
And I was doing Dr. Artie, but you can show the others.
Oh, I could, yeah. I'm sorry. I thought that Julia sent it to you.
Oh,
One thing to note, our co-chair is in jury duty, and she thought it was going to be done yesterday, but the case got extended, so she is not able to be here. Let me pull up her blurb that she prepared.
I mean, I'm happy to introduce myself at least to get started.
Oh, that's not cool.
That's okay.
We gotta make it. Um, I know she sent it to UE, and I think I was CC'd on it.
I don't think I don't think it was me.
And here we go. All right. Here is what Julia was going to say. Dr. Peter Al-Sharif joins us from Denver Health, where he serves as ultrasound faculty and also practices at St. Joseph's Hospital in Denver. He's originally from Bergen County, New Jersey, and trained at Amherst College, Rutgers, New Jersey Medical School, and completed his ultrasound fellowship at Denver Health. His professional interests include Doppler POCUS, nerve blocks, advanced cardiac ultrasound, and procedural simulation. Thank you for being here.
Yeah, thank you for having me. Should I go ahead and share my slides here?
Go for it. Yep.
All right, everyone can see just the the classic Zoom situation. You can see just my presenter view, I'm hoping, with the PowerPoint slides.
Yes, looks good.
Okay, perfect. Awesome. Thanks so much. So I'm Pete, very excited to be here and talk to you about Doppler. I think it's one of the cooler topics in ultrasound, and it's a broad topic, and so hopefully I'm going to give you a little bit of a foundational thing in terms of some physics, some applications, and some pearls and pitfalls. How to optimize your use of Doppler. Um, so what is Doppler? So this guy here is Buys Ballot, and thought to be the guy who identified the Doppler effect. There's a little bit of debate, sort of, between a few different scientists, essentially, but this is in 1845, and the purpose for identifying the Doppler effect is to identify astrological phenomenon and for sea navigation, things like this. And the Doppler effect is something we experience every day in our daily lives, right? Ambulance coming towards you versus going away from you, you notice this change in pitch. And when the source when the source of sound is coming towards you, you pick up a higher frequency or a higher pitch.
Pete, you're on mute. Sorry.
That's so weird. When did it start muting me? Uh,
It just muted. Go ahead.
Oh, interesting. Okay. Well, in any case, so Doppler effect we're familiar with from our everyday life a little bit. And in the use of ultrasound, we utilize the Doppler effect to identify the direction that things are moving, right? So when we're using Doppler to identify blood flow, we're measuring the movement of red blood cells. And so the ultrasound probe is shooting out sound waves. The sound waves hit the red blood cell. They move, the reflected sound waves move back towards the probe, and the shift in the frequency of those sound waves is what the machine is interpreting as the direction and speed of the movement. And so Doppler, for that reason, is very angle dependent. And so you can see here, this is just a blood vessel that's moving in one direction. But if you angle the probe towards that blood such that the blood is moving towards the probe, you get a positive deflection with the, Doppler waveform. But as the blood flow is moving away from the probe, you get this negative deflection. But in any case, you're able to see that there's movement and the direction of the flow relative to the probe. So what's the point in doing all this Doppler stuff? Because we're going to go into the weeds a little bit with some, the modified Bernoulli equation and all this crazy stuff. Like, what's the point in learning this stuff? Well, Doppler has applications in most organ systems that you can ultrasound. Anywhere that there's things moving, you can use Doppler to help you get a better idea of what's happening with the patient. And so identifying if there's blood flow can be very useful in resuscitations, for example. Especially in cardiac arrest, there's some evidence that, using Doppler to figure out if there's blood flow in the femoral or carotid artery is way better than palpating a pulse and correlates pretty closely to arterial line pressures. And so you've got I'm not a pediatrician, but there are lots of kids that have horrible congestive heart failure and other congenital cardiac diseases. And, being able to use Doppler to quantify how bad these things are can make you sound a little bit more intelligent when you're talking to a cardiologist. And the other really big one is for musculoskeletal applications. And so you have this black thing on ultrasound. What is this black thing? Do I cut it open? Do I start them on antibiotics? Do I start them on anticoagulation? So using Doppler can be really helpful in differentiating your unknown hypoechoic mass in soft tissue. So what are the types of Doppler? You're going to have all these buttons on the machine, right? There's CW, PW, C, P, very confusing. Hopefully I can give you a little bit of an approach to understand what all these buttons mean. So there are two types, essentially, or categories of Doppler. You've got your spectral Doppler, and so this is sort of where the title of the talk comes from, but these are your whooshes, the machine makes a whooshing noise. You have this, waveform that comes up, and then you have your non-spectral or otherwise called color Doppler, and these are your whirls. You're seeing these color whirls on the screen. And this is the pretty one. You make the joke to the patient, oh, there's a disco party going on in your heart. They never laugh. But this is the more pretty one in some ways. And so let's talk about color Doppler. So one type of color Doppler is just plain color Doppler. What that's doing is giving you the speed and direction of blood flow. And so when you have blue, it means that yep, come on in.
Okay.
Yep. Blue means that the blood flow is moving away from the probe, and red means the blood flow is moving towards the probe. Now, compare that to power Doppler. Power Doppler doesn't care about the direction of the flow. It just tells you the magnitude. And so when you're looking for, very small amounts of flow and you don't care about the directions, such as the blood flow within a testicle, we just want to know if there's flow there or not. These little penetrating arteries, we don't need to know if it's moving in towards or away from the probe necessarily. But it's more sensitive in picking up that flow. And so that's an application for that. Cool one is called tissue Doppler. And so what tissue Doppler is doing is it's filtering out all that fast moving blood that's low genicity, and it's giving you just the move, in the advanced cardiac talk and briefly in my talk, but it's mainly used for cardiac advanced ultrasound. Now let's talk about spectral Doppler. And there are two kinds of spectral Doppler that are kind of analogous to the color Doppler. So you've got your pulse wave Doppler, and that's the one where you have this little gate that has the little like T's, like there's a T this way, a T that way. And what the machine is doing is it's shooting out sound waves, and then it's listening for the sound waves to come back. And so because of this, it's able to tell you not only how much flow is going on in this gate, but also the direction, the direction of that flow. And it's only within that spot. Now, continuous wave Doppler is doing this, something similar, but in a different manner. Machine is shooting out sound waves with some of its crystals, and then with other crystals, it's simultaneously listening for the reflected sound waves. And so what's the significance of this? With pulse wave Doppler, you only get to see what the flow is in this spot. With continuous wave Doppler, you find out what the flow is throughout this, line, essentially, but you can't tell where the flow is along that line. You're picking up flow from other spots, but it is better at picking up very high flows because of the nature of the way the sound waves are emitted. And so the analogy you think of is for pulse wave Doppler, you're looking at things that have low speed, but you really want to know what that speed is at a particular spot. And so an example is like something before like an intact valve that's not leaky. And so think, when you have a garden hose, blood flow, or water or blood is coming out at a steady, non-aggressive rate. Continuous wave Doppler, you think about things that are high speed. So you've got a stenosed valve that's shooting out, blood really fast, or regurgitation. And so think, when you put your thumb on that hose, the flow is really fast. And so fast speed, continuous wave Doppler, slow speed, pulse wave Doppler. So some examples, you're going to go through these in your advanced cardiac talk, but measuring really fine-tuned things about the, right ventricle and how fast it shoots blood out into pulmonary arteries, measuring an index of cardiac output, measuring for diastolic heart failure. That's pulse wave Doppler. For continuous wave Doppler, you're measuring those fast speed things, so regurgitation through the aortic valve, measuring pressure gradients measured off of, that help you calculate how big the aortic valve opening is. This stuff is all continuous wave Doppler. So let's talk about what kinds of measures you can take. Does anyone have questions about that first part? Okay, cool. So the first thing to do with Doppler is say qualitatively, does this thing have flow or not? And so my mentor, Steve Allerhand, had a case where a patient had a foot abscess. And so, this big thing, it's red, it's hot, but just something weird about it. They had stepped on something and it's like increasing in size. So ultrasound it and it looks something like this, but then is full of flow, right? And so in this case, the patient had an aneurysm of like a tiny artery in the foot. And so that would have been terrible to open up with a knife, right? But look to see if there's flow in the structure that you're considering cutting open, just qualitatively. Look to see if there's flow in that testicle or not, just qualitatively. Is there, are you seeing those whorls? You can also look at directions and ratios of flow, right? Without doing any kind of measurements. With spectral Doppler, you put the gate on, you get these, waveform things and see, is the waveform up or is it down? Does it look big? Does it look small? What's the ratio of the waves? So qualitatively, you get a lot of information without pulling out any kind of calipers. And so let's talk about some quantitative measures. So here we're doing a little bit of pulse wave Doppler through the aortic valve. And so one thing you can measure is the peak velocity or the fastest flow that's going through that valve based on this spectral waveform. Another thing you can measure is the rate of these waves. So if you measure the time between these waves, similar to with an EKG, when you measure the time from the R to R interval, you can calculate what the heart rate is, or you can calculate the rate of that flow. And the machine does this for you, which is very convenient. And the last thing you can do is you can measure, not necessarily the last thing, but another thing you can do is you can measure something called a volume time integral. And so what that is we're tracing this waveform out, right? And the machine is automatically filling in this area. And so it's giving you essentially the volume of this little shape. And so if we go back to, elementary school or maybe middle school, arithmetic maybe. If you take something that's meters per seconds, which is a flow speed, meters per seconds, and you multiply it by time, which is in seconds, you get something in unit of meters, right? That makes sense. The seconds cancel out unit of meters. And so what VTI is that unit of meters stroke distance. And what that represents is the distance that a red blood cell moves forward during a cardiac stroke, okay? And there's, you're going to hear more about this in the subsequent lecture, but there's good evidence that just looking at that stroke distance alone, without caring about necessarily the stroke volume, they correlate really well. Now, let's talk about the modified Bernoulli equation. I mean, yuck. But basically, what we're doing is we're getting pressures from velocities, right? We're taking a measured velocity, and we're using that to figure out what's the pressure driving that flow. And so we have this, weird equation, but basically, in this example, we're measuring the flow through a tricuspid valve, right? And so you can do some arithmetic and figure out that if you measure just the speed of flow through that valve, you can rearrange this equation to figure out what's the pressure that's driving that. And I'm happy to go through the proof in more detail later, but I don't want to put you all to sleep. In any case, this is Dr. Bernoulli. Another thing you can do is measure resistivity index. And so this is really good for, testicle and ovary, but also useful in things like kidney disease. Is this kidney, showing really high resistivity, and is that why they have renal failure? And so what you do here is you're measuring flow at the artery in the testicle in this example. You get these waveforms, there's a systolic waveform and a diastolic, level, because, we have a diastolic blood pressure and there should be diastolic flow and, throughout the cycle. And so in a normal patient, you've got systole followed by diastole, but in testicular torsion, you have this abnormal thing where the diastolic flow is moving the opposite direction. So the blood's moving forward and moving backward, forward, then backward. This is not normal. This is testicular torsion. And even without this reversal, if you want to get really quantitative with this, you can measure a ratio of the systolic and diastolic, and you can calculate if this is abnormal. And each organ has a different, what's called resistivity index or ratio between these two things. But the testicle, I know, because that's the one I use this for mostly, and it's between 0.5 and 0.7. But if you're doing this for a weird organ, just look it up on the computer. It takes 2 seconds to know what the normal range is. So let's talk about pearls and pitfalls. So I mentioned, it was like the third slide of this, that Doppler's all about angles, right? And so the biggest pitfall is not having a good angle to measure that flow. And so what do I mean by good angle? Good angle means the sound waves are moving in the same axis as the blood flow. And so here's an example where, we've got a great angle. The blue is the blood flow. We've got the gate that's, right in line with the flow. We get a measurement that's accurate. But how often do you get flow that's moving towards and away from the probe? So a little bit inconvenient. The machine allows you to do this thing called angle correction. So in this case, we don't have a good angle, right? The flow is not in the same direction as the green line. But you get this little dotted line that comes up, and you can change the angle on that dotted line, and the machine will do trigonometry to figure out, what the flow would be expected, your sine, cosine, etc. The problem with this is it's very error prone. So as you move that angle more and more perpendicular to the flow, the machine's kind of guessing what the flow is. You're picking up signal and noise rather than true flow. So you really want to get the gate in line with the flow as much as possible. So get it in line with the flow as much as you can. I honestly forget what this meme was referencing, but in any case, so here we've got an example of, it was steering. We're talking about steering, so steering a boat. So angle steering. You sometimes see this button on the machine that says steering, and so you'll be able to, toggle it left to right. And this helps you pick up, color flow that is not in line with your probe. And so we've got two examples here. This is an artery that's flowing in this direction. And so because the steering is angled this way, the machine thinks the blood is moving towards the probe. In this case, we've got the steering pointing in this direction, and the machine's accurately picking up the flows moving in that direction. Remember, blue away, red towards. And so what we want to do is get that steering angle in line with the direction of the flow as much as possible. And that'll give you the best interpretation of what the flow is doing. Now, let's talk about aliasing. So, we're doing this Doppler thing in an artery, and you get this crazy, very colorful and pretty, display of blood flow. And we're getting this flow that's shooting off the page, coming around to the top. Like, what's going on here? What do I do with these very wacky looking measures? You can kind of think of like this phenomenon where you take a thing moving faster, like a car tire, and the direction of the rotor. It's based on what's called a pulse repetition frequency, or basically how often that machine and listening. And if you want to read about this, that's essentially what it is, shooting out sound waves and listening and alternating between them. And so how do you fix aliasing? So here we got an example of some aliasing on Doppler. And so one thing you can do is you can change the scale of the Doppler. And so by pinching or opening your fingers, usually pinching, you'll make that whole waveform smaller. And this is not just zooming in and out. This is changing the way the machine shoots sound waves out. And by changing the frequency of sound wave, emission. And so you have to do this while the machine is shooting sound waves out is the pearl. So I can't tell you how many times people are trying to do this, just sort of trying to zoom in and out, but it has to be while the machine is shooting sound waves out is the important part. The other way you can do this is by changing the baseline. And so just by simply dragging that green line down, sometimes you can address this aliasing issue. And this can be done either while the exam's happening or afterwards for the baseline aspect. Now, you can also, we talked about aliasing happens with the color Doppler too, and here we've got this crazy blood flow. Like clearly this artery is shooting blood towards the probe, but it's showing up blue, which says away from the probe. And so in this case, you can change the probe to something that's higher frequency or lower wavelength, and that gives you a better pulse repetition frequency when you're at deeper depths. You can check your preset, make sure that you're in the right preset because different presets have different color Doppler settings. You can check that the color box is not overgained. Maybe that's part of the problem. And so, but just while the color box is up, you can change your gain up and down and see if that helps address the problem. Okay, let's do some practice cases. I sent out this Mentimeter link. I hope this works. But just a few cases that, maybe drive home some optimizing things. And the little QRs in the cases as well. I'll pull up the little audience response thing on my end too, so we can see what you guys are thinking. Okay, so let's do the first case. So here, we're doing some Doppler. We're using pulse wave Doppler. We're measuring some blood flow. And, we're getting this waveform here. And so are you guys able to see that word cloud sort of response thing? I mean, just type in maybe some thoughts about what's wrong here. What could you do to fix this? These types of things. Just, one or two words. Nice. Yeah, I absolutely. You guys are all correct. It's all the angle here. You're sharp. We're all perpendicular to the blood flow. So maybe you try to do this steering thing, right? And when
Peter,
you do that steering
your
thing, you get
share stopped. I'm
that's
not
so
sure if the
weird.
word cloud interfered with it.
Oh, that's definitely it. Let me try. Can you see now?
Yes.
Okay, cool. Sorry about that. So yeah, maybe you try doing that angle correction thing and you get this kind of, crummy looking waveform here that's all filled in and whatnot, but it's bigger for sure. So in this case, now we've moved the angle of the probe this way. Maybe you're doing a little angle correction still, and you get this much more crisp waveform that gives you a more accurate measure of flow. All right, so go to the next slide, question and the Mentimeter thing. And, again, some thoughts. What's going on here? What's wrong? What could we do better? And so what we're doing here, I know the image is kind of small, we're measuring flow through the mitral valve, and we're using continuous wave Doppler. And yeah, I don't see any responses. I'm worried that it's a problem with the Mentimeter thing. So I'm just going to keep going here. But here's what's the issue. We're using continuous wave Doppler, through a nice big open valve that's not leaky. And remember, I told you that's not the choice of Doppler for when you've got, low flow states through a, nice intact valve. And because we're using continuous wave Doppler, we really don't have a sense of, where is this flow being picked up? Is it up here? Is it down here? And it's a less precise measure of the flow. And so if we want a really nice precise measurement, we want to use that pulse wave Doppler. And when we do that, we get these nice hollowed out waveforms that are measuring blood flow at just a single spot, and you're able to identify what the flow is truly at that spot, gives you pressures and helps you figure out how their diastolic heart failure is. Okay, do the next one here. So here we've got an artery and we're measuring it. We're taking a look with color Doppler. And so, take a look and tell me what you think. If anyone wants to just jump in and just say what their thoughts are, that's cool too. So not a lot of color going on here. There's a little bit of red, but not much. And, we know that there's probably a lot of flow in there. It should be a lot more robust. So in this case, what we've done is just simply increase the gain. So when you have the color box open, you increase the gain and it changes the way that the machine is displaying these flows. It doesn't change anything about how the machine is picking up the flow, but it's just making it show up a little bit better. And so that's the first thing you can do to troubleshoot this, just increase the gain and just see what happens. In this case, we've got a better picture of what the flow looks like. And now let's say you go crazy with it and you increase gain more. You start picking up all this crazy flow that doesn't represent any actual, all this color that doesn't represent actual flow. So you're kind of titrating your gain to, below where you see this kind of speckled, red and white and yellow and blue stuff happening. Okay. Here we're doing some, pulse wave Doppler, and we're getting this flow, which we expect in the positive direction, but then you're getting this kind of mirrored thing. And that looks weird. And I don't know that there's flow happening in both directions at the same time. That doesn't really make a lot of sense. And so what's happening here is a phenomenon called spectral mirroring. And so all you do to fix this is reduce the gain while you're shooting out pulse wave Doppler or continuous wave Doppler. And so what's happening is the machine is not interpreting it's not picking up this artifact anymore. And the importance of this is why can't I just ignore this, thing and just measure it here? But this is an indicator that your gain's too high. And by, appropriately reducing the gain, you get a more accurate representation of what the flow is in the real direction. Is that clear? So just reduce the gain a bit if you see this phenomenon. Okay. Here we're measuring some flow through the portal vein. And so nothing. Portal vein thrombosis, call surgery or heparinize. So to address this, we can adjust what the sensitivity of the Doppler flow. Okay. And this is not an adjustment to gain. This is actually an adjustment of how the machine's shooting flow out. And so you see here, by adjusting the scale and adjusting this thing called the wall filter, you're able to get more, you're able to pick up this lower flow state. The biggest way this happens is where the wrong setting is being used in the machine. And so just make sure you're using an appropriate preset for the organ that you're imaging and the right probe, obviously. And if you're fancy and you do a lot of button pushing, you can adjust some of these things in the image acquisition settings in the machine. And so here's the opposite example, where the wrong preset's being used to image this artery. But when you correct the preset, you get rid of this sort of crazy aliasing artifact, and by increasing the scale in the wall filter. Okay. Another example. So remember what this thing is called. This is called aliasing, where the flow is kind of shooting off the page and coming around and impossible to interpret. And so what we're measuring here is through a tight valve. And so by switching to continuous wave Doppler, we're able to measure these high flows without having this aliasing phenomenon. We don't know, where along this line that flow is, but that's okay in this case, because we know that the flow is going to be really high just beyond that tight valve. Okay, here we have a testicle, and there's like a little flow, but not much. Call surgery. If you switch from this color Doppler to power Doppler, we're able to see lower flow states. And so this is the appropriate way to image, you know, things that are small and have small amounts of flow. And so for testicle, this is the Doppler you want to use when you're really evaluating for torsion with color, with, you know, the whooshes or the whirls, I'm sorry. So just a little summary here. It's all about the angles. The biggest problem that happens is that the angle of your pulse wave Doppler, the probe, is perpendicular to the flow. Just by adjusting the angle, you address many of the issues with Doppler. Check what your probe preset is. You don't really need to go into the machine settings necessarily. Just by having appropriate preset for what you're imaging also addresses a lot of issues. You're using color Doppler for when you care about the direction, and then you're using power Doppler when you have little, small movement things where the direction isn't as important. And then similarly, using continuous wave Doppler for things that are moving really fast, and pulse wave Doppler where you have things that are moving slow, but you need to know what the direction of the flow is. And you can address aliasing using adjustments to the scale on the machine and moving the baseline. The scale has to be adjusted while the machine's shooting sound waves out, but the baseline can be changed afterwards. And so that's all I've got. If you've got any questions, please feel free to reach out. And thank you for having me again.
Amazing. Thank you. There are a few questions in the chat.
Let me
Um,
pull it. Sure.
and I think they refer to specific slides. So if people who have those questions can unmute and refer to what their questions were, that would be ideal.
I can do that. Can you go back maybe 8 slides, and I can tell you. All right. Go forward. On this one, the
Yeah,
scale on the left and the right looks the same, but you mentioned just can you say what you did
absolutely.
there again?
This is a little confusing. No, absolutely. So in the original, there's not a lot of flow that's showing up. Here's your scale in terms of this is a representation of how the machine is shooting sound waves out, right? This scale here. However, just by increasing the gain on the machine, it's only changing how that flow is being displayed on the screen. And so your scale is identical. But the gain, just by increasing it, you get a better image of this flow. And so how did I know to change the gain and I didn't need to, switch the setting or switch the probe? It looks like there's not a lot of flow going on in these areas at all. And so this is like the first thing you try is just by increasing the gain just a touch. It's really only just changing how this data is displayed to you. And so yeah, that's the first thing you try. And then the other example that's kind of analogous is where we're changing the scale and the wall filter. And maybe in this case, I've tried changing the gain and it really doesn't look like it's changed at all. There's like zero flow in here. So in this
Perfect.
case, I realize I need the machine to be more sensitive to that flow. And that's why we need to change these things. And that these things are adjusted by changing the machine preset, but you can, if you're, goofing around in the machine, change them individually as well.
Thank you.
And then Antonio, you had something. Did you want to ask that as well?
I mean, Peter just touched upon it exactly.
Okay, perfect. I thought so. I just want to make sure. Okay.
For the
I had a
technical example, was that you said the alternate color mode there?
It's just the beginning of your question I missed, sorry.
On the testicle example, you touched it up by changing the color mode.
Absolutely. So for this here, and to be fair, when you look at consultative exams, they're using the color Doppler with color. This is confusing because there's a category of a Doppler called color Doppler. But then within color Doppler, there's something called color Doppler and power Doppler, right? And so I'm talking about color Doppler and then color power Doppler. When you look at how like when you send someone to radiology for a testicle ultrasound, you'll see the color, with red and blue. They have different machines that are more powerful than ours in many aspects. And when you do need to know the direction of flow, you need color, as in meaning red and blue. But when we're using our bedside ultrasound machines, we really want to know if there's any flow at all in a low flow state. You switch to this thing that's called power Doppler. And so on most machines, the way this is represented is the button that's C, the letter C, and then the button that's letter P. And so this is different than the button that says CW and PW. So there's C and P, and then there's CW and PW. So, this one will be PW, and this one will be CW. Whereas this one is represented as a C, and this one's represented as a P. Does that make sense why, or the difference in color? Perfect.
Okay, one more chance
What-
for
While we were talking about pulse wave Doppler, a very brief question about the difference between steering and angle correction. Could you elaborate on that a little bit, please?
Absolutely. So your angle correction is something that's used in, here, I'm just trying to go to the good slide. So your angle correction is something that is being used when you're using a form of spectral Doppler, so either pulse wave or continuous. And what the machine is doing is it's using trigonometry to say, okay, the flow is this direction. I'm getting this vector of the flow. The guy doing the ultrasound, this is what the machine is thinking. This guy doing the ultrasound is saying, no, the flow is actually in this direction. And so it uses trigonometry to say, okay, if this angle of the triangle is this, and that angle, or this length of the triangle is this, and that angle the guy is telling me is this, the hypotenuse flow rate should be this. So that's your angle correction. It's used in spectral Doppler. Your steering is using the same mathematical principles, but it's something that's used for color Doppler, meaning with the red and the blue color. And in this case, you see this little thing here, the pulse wave gate. But I'm just showing you that we're just talking about the color aspect of this, and that's when you use steering.
Great, thank you.
Of course, yeah.
Can I ask a kind of a follow-up question to the last couple comments? So within color Doppler, there is a subset of C and P, and those are color and power. And then within spectral Doppler, there is CW and PW. Could you just kind of say that again?
Absolutely, because it's so confusing. And I can't tell you, like when I was an intern, how much time I spent just figuring out the buttons on the machine. And so one thing to do is when you have time, like go through and press all the buttons. Maybe like, don't break anything in the machine, don't change any settings. But, all of the buttons that you're supposed to push, try pushing them and see what they do. And so this is important, so I'm just going to go through it one more time. You have two forms of Doppler. There's your spectral, which is, your whooshes, like it goes whoosh, whoosh, whoosh. You get a waveform. There's non-spectral, which is also called color. Very confusing, right? And so you get colors like things that are swirling around on the screen. And so for that non-spectral or color Doppler, there are two categories. There's color Doppler, and there's power Doppler. And so your color Doppler gives you directions of flow. It gives you stuff that's both red and blue because it tells you by the color which way the blood's moving. And by how red or how blue, you get an idea of the magnitude of flow. Power Doppler is ignoring that direction aspect, and you're just getting how much flow there is based on how yellow it is. For pulse wave Doppler and continuous wave Doppler, for pulse wave Doppler, you're getting an idea of flow at a really discrete point. Continuous wave Doppler, you're getting an idea of flow all along this line. And this is like the button is PW and CW for this. On most machines, at least.
All right, thank you very much. We are going to move on to our second speaker, who I get the pleasure of introducing. Dr. Rizvi is faculty at Columbia University College of Physicians and Surgeons. She is the director of their residency ultrasound track and co-director of the ultrasound academic practice track in the EM residency there. She's going to be talking to us today about advanced cardiac ways to use Doppler to advance your focus exam. Thank you for being here, Munaza.
Thank you. Hi, everyone. Thank you so much for having me. I would first like to thank Dr. Elshay for doing an excellent job in teaching us basic and advanced Doppler principles. I would like to use that as a foundation and speak to everybody about Doppler applications in cardiac ultrasound. So this lecture is designed to be, sorry, I'm just going to fix this a little bit, an introductory lecture in some of the advanced techniques that we can employ in cardiac ultrasound. We will be going through clinical case examples, and I will walk you through how to acquire and interpret some of the advanced Doppler techniques in 3 major domains. So we're going to be talking about systole, we're going to be talking about diastole, and pericardial effusion and tamponade. So let's start with systole, and also on the LV side, a common clinical scenario: an adolescent male presents to your ED with non-specific URI symptoms and chest pain. On exam, he looks dry, tachycardic with soft blood pressures, and it's the flu season, so the dreadful myocarditis is on your differential. So you start with your 4 basic views. This is a parasternal long view, and I know for this audience, I don't have to go through all the anatomical landmarks, but just assessing by this image, the systolic function looks good. I'm sorry if it's coming out a little glitchy, that's a PowerPoint issue. The myocardium is thickening uniformly. The chamber size is decreasing at least 35%, if not more, during systole as compared to diastole. And this is a parasternal short view of the same patient. Again, no concern for regional wall motion abnormality or systolic dysfunction. No, it's not coming really well on the video, but if anything, the chamber is hyperdynamic and you're concerned for dehydration. So how good are we at assessing systolic function? PEM physicians are actually pretty great at assessing systolic function. In a study published in 2022, the characteristics to interpret, test characteristic to interpret systolic function at bedside are almost perfect. But how many of us have questioned ourselves when we're doing it in real time? So I think it's important to reaffirm your assessment with quantitative measures, and we will go through exactly how to do that. So one of the established parameters in adults and one that is gaining traction in pediatrics is cardiac output. How does cardiac output help us figure out systolic function? Imagine you have a water pump which fills your bathtub every day. One of the ways that you can be sure if the pump is working well is looking at the rate it's filling the bathtub. If the rate is as it should be, then your pump is normal. And using the same analogy for your heart, you can determine if the pump function of your heart is adequate by looking at the rate at which it's pumping blood into the outflow tract per minute, which is your cardiac output. So how do we calculate that? Remember this equation: cardiac output is equal to stroke volume multiplied by heart rate. So stroke volume can be calculated by taking into account the area of the pipe, or the LVOT area, and the distance the blood travels in the LVOT with each heartbeat, which was the VTI that Dr. Elshay mentioned. So the 3 components you need for cardiac output calculation are LVOT area, VTI, and heart rate. Let's start with the LVOT area. You want to get a parasternal long view. Make sure your LV is not foreshortened, and you want to focus on the aortic outflow tract. Make sure your LVOT area is as horizontal as possible. Then the area on the LVOT tract where you want to measure is the ring area at the aortic annulus. This is an imaginary ring located at the insertion or the hinge points of the aortic valve, measured in mid-systole. And mid-systole is important because it's a time of peak ejection. You're going to place your calipers from inner edge to inner edge. And one of the things that you want to make sure is that you're not your measurement is not displaced more than 2 millimeters, because any small changes in the diameter measurement can be potentially amplified in the calculation. And I would also like to mention that multiple research studies have shown that the most frequent error in calculating cardiac output measurement comes from erroneous LVOT measurement. So this measurement here and the exact location of it is really important. Now, let's talk about how to get your VTI. You get your standard A4 view with transducer at the PMI and probe marker at 6 o'clock position if you are doing it EM way, and probe marker at 3 o'clock position if you're doing it cardiology way. Once you have a good A4 view, you want to fan the probe anteriorly to get your 5-chamber view. So in your 5-chamber view, you are able to recognize all the 4 chambers, but also have aortic outflow tract right in the middle of the screen. And once you have your A5 view, you will then turn pulse wave Doppler. Now remember, pulse wave Doppler, as we talked about, just tells you about the velocities of the blood at a certain point. You want to measure at the same level that you took the LVOT measurement, so just proximal to the aortic valves. Your gate, this is the sample gate of the pulse wave Doppler. You can modify it on your machine. It should be anywhere from 1 to 3 millimeter. We don't want to calculate too many velocities. We want to calculate the middle part that's like really laminar flow. And the sweep speed, which is part of your cardiac preset, but it tells you how many cardiac cycles per image you're seeing. For any cardiac measurement in pediatrics and also in adults, it should be anywhere from 50 to 100 millimeter per second. And it's important because the sweep speed tells you how many cardiac cycles you're getting. So if you're having like 10, it'll be really hard to do measurements. And if you're getting you're getting only 2, you're not getting a good assessment of their cardiac waveforms during 3 to 5 beats. So this will give you.
I'm just going to stop because there's a question right there that might be better to address in real time. Should VTI use pulse wave or continuous wave?
So VTI should be pulse wave, because remember, you should only use continuous wave for really high velocities, and those velocities are normally your regurgitations or your stenosis and stuff like that. So continuous wave across valves are mostly used when there's like abnormally high flow. For regular VTI or regular valves, you should use pulse wave. And also, it's really important to know where you're measuring it. So the pulse wave tells you exactly where you're measuring, right? So just making it a little bit simpler. Are you measuring at 5 centimeters? Are you measuring at 10 centimeters? Whereas like continuous wave doesn't tell you where exactly you're measuring. It just tells you the velocity of blood across the whole screen. So for LVOT, it's really important you do pulse wave, because again, we have to measure it exactly at the area we measured LVOT area. I hope that answers the question. So as Dr. Elshri mentioned, if you have aliasing, you can either increase your pulse repetition frequency, or you can adjust the baseline so you make sure you're viewing all your peaks. And you want to adjust your gain and you want to adjust your filter. You want to get waveforms that have low or no spectral broadening, by which I mean there should be like hollowed out like this, and not be like too filled in, because when it's hollow, it means that you're getting similar frequency velocities and laminar flow. Whereas if it's broadened or you have spectral broadening, then it just means you're getting turbulent flow, or you're maybe too close to the IVS, or you're too close to the aortic valve or something like that. So this is important. It's not a mandatory step, but it's good. It's a good quality signal if you have 0 spectral broadening. And once you have an image you're happy with, you take a still, you press a calculator, and depending on what preset you have, you will click on aortic VTI, and you will get an arrow, a tracing arrow, and then all you have to do is just trace your VTI triangles. And if you're good at video games, this is easy. Now, ideally, you want to have 3 measurements and average them out. Normally, when you do that and you're doing multiple heart rates and multiple VTIs, the machine gives you multiple cardiac outputs too. So you can average the cardiac outputs as well. So here I have measured 3 different peaks. So you can see VTI here, here, here. And for heart rate measurement, you can either manually place it in the machine if you have the option to. I know some of our scenarios have that option, or you can click on the heart rate on the calculator, and then you will have to place calipers in between two peaks. So another important part here is that make sure you're capturing heart rates of the same heartbeats that or cardiac cycles that you're measuring VTI in. So that just makes all of these things make your measurement much more accurate. And sweep speed, again, is important here. You want to make sure you're getting at least 3 to 5 cardiac cycles, not 10 or 15, and not like 1. And this gives you the heart rate up here. And when you've already done your LVOT first in the calculator, and then you've traced out your VTI, and then you've measured heart rate, the machine spits out cardiac output for you.
Wait.
So
Naza, I have a question. How do you change the sweep speed? I guess I've never done that before. Is it like a setting that's on there, or it's preset, or how does that work?
yeah, cardiac presets normally are 50 to 100 most of the time in adults and peds. You can, if you're not using any preset, you can change it. But if you're already in a preset, it comes preset. So you can't really change it. So if you want to just look at the image, and if you're getting too many cardiac cycles, maybe come out of that. But most of the cardiacs, even the adult echo setting and the piece, at least in our machines, I only have reference of our machines, they have 50 to 100, so it's appropriate. So I have never had to change it. Okay, so in summary, you can calculate cardiac output by measuring your LVOT area, and you're measuring your, tracing out your VTI and measuring your heart rate. And again, it gives you the cardiac output or the stroke volume. Now, you can use absolute values for cardiac output, but a preferential method, by at least from cardiology literature, is using cardiac index, which is dividing the patient's cardiac output by their BSA. Generally, a cardiac output of 2.5 to 4 liters per minute per meter square is considered normal in older children, and neonates and younger children have higher cardiac outputs. But in general, it is encouraged to use trends and correlation with perfusion parameters rather than absolute values. And to piggyback on that, one of the exciting things about cardiac output is that it's not a static measurement, it's a dynamic measurement. So it changes as the patient's condition is changing. So you can actually use it to guide your management. How do we do that? If a patient's coming in order to ascertain if the patient is fluid responsive, you first get a cardiac output and supine position, and then either you can give a rapid fluid bolus, or you can do passive leg raise for 30 to 90 seconds. And a change in 10 to 15% of stroke volume means that the patient is fluid responsive. So one of the ways I can think of implementing is that if I have a patient with myocarditis and I'm worried about their cardiac function, and I don't know right now whether I should give them more fluids or start pressors, or a combination of both. One of the things is that you can do cardiac output measurements at baseline and then after giving them a bolus. And if there's no change in stroke volume, then that patient does not need more fluids. But if there is a change in stroke volume, then you can additionally fluid resuscitate. So it really helps. So when we learn about any technique, it's also important to learn about.
There's another question. It asks, in the last talk, that was described as volume time integral, but you're calling it velocity time integral. Is that a semantic difference, or is there a subtlety that we're missing?
So I normally call it velocity time integral, but I will double check that if I've been calling it wrong all this time. Sorry about that. So I will double check that. So now that we were talking about pitfalls. Cardiac output is a measurement with high inter-observer variability and also variable feasibility among performing physicians. And it also becomes inaccurate in cases of aortic valve disease, severe MR. And since heart rate is an essential component in calculation, ectopic beats and AFib can cause beat-to-beat variation and variable stroke volume. So one of the solutions is to average out 5 to 10 beats and exclude any post-ectopic beats. Now for this, you have to have an EKG attached to the ultrasound machine. So you can't just make an assessment purely on beat mode ultrasound, but if you have that availability, then you can do that. All right, now that we have the LV side of things covered, let's move to the RV side. One of the Doppler measurements that we can use to assess for RV systolic function is S prime. So now we all know and teach TAPSE, or tricuspid annular plane systolic excursion. It is an independent predictor of mortality, and basically it's an M mode measure used to assess longitudinal RV systolic function. So basically it checks when you put an M mode, how far is the displacement of myocardial fibers towards the apex during systole. And S prime is basically the Doppler counterpart of TAPSE, where TAPSE tells you how far the myocardial fibers have been displaced during systole. S prime tells you how fast they have been displaced. So obviously, if you're in good health, you would run fast and run far. So how do we calculate S prime? For S prime, you want to acquire an A4 chamber view that is RV focused. And by that, I mean your RV free wall should be readily visible. And once you have a good view, you want to turn on tissue Doppler. So we already went through how to activate tissue Doppler and how it quiets down the Doppler signal from the blood flow. So the only signals you're getting are Doppler signals from the myocardial movement. You're placing the TDI sample gate approximately 1 centimeter towards the apex from the lateral annulus. And the reason you want to do that is you don't want to accidentally catch atrial velocity, you only want to catch ventricular velocity. The sample size, the sample volume gate in TDI is different from blood. So instead of 1 to 3 millimeter, it's 5 to 10 millimeter, which is larger. And this is what we were talking about, aligning the beam and changing the Doppler angle. For S prime, you don't mess with the Doppler angle. You're just aligning your beam as much as possible with the RV free wall. So don't move the Doppler angle at all. It's just more about this. So by pressing tissue Doppler again, you get the following waveform where the positive deflection on the y-axis during systole represents the systolic function of the RV. You can again press on calculator, go on the RV side, and then it should give you a button that says S prime, and then you can measure the peak velocity by bringing the cursor to the peak of the waveform. So any value above, and these are adult data, the pediatric is age-based, weight-based, everything. So most of the time when we're screening, we just use adult data. So the normal value is anything above 13 to 15 centimeter per second, and anything below that is abnormal. So this patient has normal S prime. This is a case example from a patient recently that we did, and she also had a normal S prime of 16. And anything below 13 is abnormal. So if you're getting S prime of 8, that's abnormal. So S prime is actually pretty easy and moderately reliable, especially in pediatrics because we get really great windows. But one of the limitations, just like TAPSE, is that it only evaluates a region. And if there is concern of regional wall motion abnormality, then that's not something that's accurate and more kind of pertinent to adults. But we can still have like congenital patients with myocardial post-op surgeries, like they can have regional wall motion abnormality. So that's something that you want to take into account. It's also load dependent, so it can be artificially high in hyperdynamic heart with severe TR, and it can be artificially low in hypovolemia and pulmonary hypertension. Sorry, and in case of pacing and post-surgical myocardial measurements can be inaccurate as well. All right, so we're more than halfway through. Let's switch gears to diastole. Good news is that we already know how to do tissue Doppler, TDI, so this will be easy. So this is not something that we come across a lot in pediatrics, but something that we should start considering. The classic clinical scenario could be an 18-year-old male who's morbidly obese, has type 2 diabetes. We see a lot of those patients as well, who's coming to you with complaint of exercise intolerance. His vitals are normal. You only see hypertension on his vitals. And your fellow says that the systolic function looks great, but you do worry about his diastolic function. And the reason why you worry is that around 57 million people around the world have heart failure. Half of them have diastolic dysfunction or heart failure with preserved ejection fraction. HFpEF is some of the terms that you've heard our EM colleagues and our EM residents use. You also know that obesity, diabetes, hypertension are all really highly associated risk factors with HFpEF. So that's one of the reasons why you want to see whether it's maybe undiagnosed diastolic dysfunction or is it some kind of pulmonary decongestioning. So E prime, one of the ways to assess diastolic dysfunction, which is now one of the primary steps in screening for these patients, is measurement of E prime. Think of E prime as an opposite of S prime. E prime measures how fast the muscle relaxes in early diastole. How do you obtain it? You again get an A4 view. And for this one, as for S prime, you were making sure your RV free wall is really visible. For E prime, you want to make sure your mitral annulus is really visible, so the area around the mitral valve insertion. And you want to activate your TDI and you want to align your ultrasound beams. So for septal annulus, you will place a TDI at the medial insertion of the mitral annulus. And for the lateral E prime, you will place TDI measurement at the lateral insertion of the mitral annulus. And this is basically the same waveform that you got in your S prime, but here you're not focusing on the positive deflection, you're actually focusing on the negative deflection, which is the E prime or the measure of relaxation. And you want to measure at the peak velocity, and you also want to measure modal velocity, which is the brightest part of the signal. So you want to adjust your gain, filter, all of those things, make sure there's no feathering, there's no spiking of those waves. These are E prime values for adult population published in the latest ASC guidelines. Important to note again that E prime values are higher and age dependent in pediatrics. There's separate data sets published for neonates, older children, and adolescents. But going through those graphs is beyond the scope of this lecture. Just remember 7 for septal and 10 for lateral annulus. And ASC does recommend that you obtain, when possible, you should obtain both and average them out. So this is an example of a normal septal E prime. Right here, you can see it's measuring around 9.2. So anything above 7 is normal. This is borderline E prime for lateral. It's 10. So 10 or more than 10 is normal. So just remember those numbers 7 and 10. This is an example of my patient just yesterday. She has a beautiful E prime, definitely more than 10 lateral annulus. And the same thing on the septal side, it's more than 10, so I'm not worried. This is what a abnormal E prime looks like. You can see it's like close to 5. So again, those numbers are important, 7 and 10. You don't have to like spend too much time. You're just gonna click on the E prime part of your LV side and put your cursor at the maximum velocity and it'll spit out the number for you. So E prime actually performs really, really well characteristics-wise in terms of sensitivity and specificity for detecting diastolic dysfunction, and that's why it's one of the primary steps in looking for that. However, it's not something that's a standalone test. You do need other supplementary measures for definitive diagnosis. But it's really good for us in the ED because, again, most of the time with POCUS, we're screening, we're not giving definitive diagnosis of some kind of systolic or diastolic dysfunction to patients. So it's really good. And it also is affected by similar pathologies such as valvular pathology, cardiac surgery, AFib. But there are ASC guidelines on these special populations, and it doesn't mean you can't assess diastolic dysfunction. You just need more supplementary parameters to measure those. All right, now let's talk about our last pathology, which is pericardial effusion. This is something that we have come across once or twice in our career so far. An adolescent, no past medical history, coming in with like chest pain and syncope and was recently diagnosed with flu. And you see the vitals and you're a little worried about this patient because they have really soft blood pressures or hypotension. So again, these are the B mode images of this patient. I'm sorry again that the videos aren't coming, they're a little bit glitchy, but as you can see, there is anechoic fluid around the patient's heart. So one of the B mode signs of pericardial effusion, as you already are aware, are fluid circumferentially around the pericardium. You can qualitatively or quantitatively quantify it. And we also know that a very sensitive marker of tamponade is right atrial collapse during systole and right ventricular collapse during diastole. So what are the Doppler measurements that can help confirm tamponade? Now, I wanted to emphasize that it's confirming tamponade and not diagnosing it. I think in terms of test characteristics, the B mode actually performs better than the Doppler measures. So enter respiratory variation in transvalvular velocities. This can be used to confirm sonographic tamponade. What do I mean by that? Remember pulsus paradoxus and tamponade physiology. The exaggerated drop in LV filling during inspiration can actually be visualized with the help of Doppler ultrasound. So how we do that? For transvalvular inflow velocities, you're again going to get your A4 view and place your pulse wave Doppler in between the mitral leaflets. Showing. And ask the patient to breathe normally and give verbal cues, or you can give verbal cues for inspiration and expiration, so you can make a note of when that's happening on your Doppler waveforms, and I'll tell you why that's important. So this is the waveform you get, and we saw some of this in Dr. Elsher's lecture as well. So the inflow pattern of mitral valve consists of two waves within one. The taller one is called the E wave, and the short one is called the A wave. And this is more going into diastology. We're not going to focus on that. But for mitral inflow velocities, what you're focusing on is the peaks of the E waves. And you're focusing on the peaks of the E waves during inspiration, and you're focusing on the peaks of the E waves during expiration. And if the difference in the peaks or the variation between the peaks is more than 25% on the mitral side and more than 40% on the tricuspid side, then you have confirmed pulsus paradoxus in your patient and tamponade physiology. So this is an excellent pocket card by ASAP going through normal changes in inflow velocities when you are in normal condition versus when you have a patient with tamponade. So a normal is less than, or like more important to remember, abnormal. So more than 25 on the mitral side and more than 40 on the tricuspid side is abnormal. You can calculate the variation by looking at the maximum velocities of the E wave, and just putting that into equation, or you can qualitatively assess as well. Again, same technical things. You want to average 3 to 5 cardiac cycles. Here, you might want to increase your sweep speed if the patient is not breathing that fast, because you want to capture at least 1 to 2 respiratory cycles as well. And then also you want to make sure that you're not making the patient nervous and you're asking them to breathe forcefully. It should be similar breathing force between inspiration and expiration. And you can also look at it qualitatively. I mean, this is one of the, I don't think if I can assess like more than 25% just qualitatively, but this is one of the examples given. Again, just drilling that down, 25 on the left side and 40% on the tricuspid valve, which is at 40% of the tricuspid. So this is an example of a normal transannular velocity profile in the absence of tamponade. This is a healthy 6-year-old female. You can even qualitatively assess that the peak on the E peak on the inspiration and expiration is not that variable. This is one of the examples on ASE guidelines about a patient with tamponade. You can see that overall the cardiac output has also decreased, the modal velocity is decreased, you're not seeing really bright signals. But also this is a patient with tricuspid flow velocity, and the variation between the inspiration and expiration was calculated to be 49%, so abnormal. And this is an example of the mitral inflow. Again, you're seeing your E and your A wave. Now here, the E is decreased at a separate topic because that patient might be in diastolic failure. But you can see that there is a variation between the expiration and the inspiration of around 25% or more. So some pitfalls for this measurement: patient has to be breathing normally, like we talked about. Evidence-wise, mitral inflow is more reliable. It performs well, better than tricuspid. There are no established cutoffs for ventilated patients, so we continue to use normal cutoffs for them, and it could be inaccurate. We don't know. And similarly, valvular pathologies and cardiac surgeries cause inaccurate measurements, but COPD asthma is an important confounder to remember for this measurement, because this measurement is affected by respiration. This is just a summary slide going over test characteristics of the measures we talked about really briefly, because not enough time to go into the depth of this. But green represents something that has high performance, blue represents something that has good performance, and yellow represents something that has moderate performance. So as you can see, E prime performs really, really well in terms of test characteristics. So in summary, for systole, you can use cardiac output to indirectly assess cardiac function, although better to use it for trends than absolute values. S prime is a reliable Doppler measure for RV systolic function, although you should always take into account regional wall motion abnormality. For diastole, E prime is great, good for us because we can screen patients, but definitely don't give definitive diagnosis of diastolic dysfunction. And then it also, especially in pediatrics, there's a lot of confounders. So better to be aware of all the different grades and different pitfalls of different waveforms. And for precardial effusion, remember the numbers of 25 and 40, and then make sure you are keeping an eye on their breathing as well. Thank you so much for everybody's attention. These are my details, and I'd like to thank Dr. Lorraine and Dr. Joni Rubiner for their critical feedback, and I will wait to answer any questions you have. Thank you.
There was one question that was posed more about just pericardial effusions as opposed to Doppler, but the question was, at what point do people call it an actionable effusion? 5 millimeters, 10 millimeters, and when do you measure the size, if ever? You muted yourself, Manasa.
Oh, sorry, Matt. I zoned out in the first half of that question.
The question was more about just pericardial effusions in general and the size at which people would call it an actionable effusion versus trace versus physiologic.
Yeah, I think what matters for effusion is, sorry, the sun is, what matters is the rate of what it's collecting as opposed to just the overall size, because you can have a patient that has a chronic effusion that's really, really large, but it's not causing tamponade because that patient has had time in years to develop that effusion versus a healthy person who has maybe just small going into moderate effusion, but it's causing tamponade. And one of the good things about ultrasound is that sonographic tamponade is actually apparent before clinical signs appear. So before patient has hypotension, you can see sonographic tamponade. So good to look at, yes, the size of the effusion, but also what that effusion is doing to the right atrium and the right ventricle during systole and diastole respectively. And then even if it's a big effusion and there is no tamponade, it'll still cause the tenting of the atria and the ventricle. So the cycles are also important to look at the right atrial collapse in systole and right ventricular collapse in diastole, because if the right ventricle is collapsing during systole, that's what it's supposed to do. So you have to look at the valves, at the opening of the valves, and then looking at the free wall of the right ventricle.
And Rosemary, do you want to ask your question?
Yeah. Hi, Manaza. This is incredible. My mind is blown to smithereens. I don't know how many neurons are left in there, but I wanted to ask, what additional utility we as emergency medicine physicians who are so, yes, POCUS experts, but we don't exist in a vacuum, and we have all the other things that we need to get going on. What would you say is the other additional utility of learning this, doing this? Because we thought, oh wow, the frontier of EPSS, look, we taught you something quantitative. We're going to call cardiology. Where do you see this actually helping you and the patient?
Yeah, so I'm actually really excited about it and hoping to do a lot of research in this arena. In terms of research that's already there, there are some PICU studies that are looking at cardiac output. And there are some definitely like 3 to 4 studies that are looking at a diastolic dysfunction and presence of which in like kids in septic shock and kids that have been admitted to PICU with septic shock. So I think there's just a lot to uncover, which is exciting, but I don't think we have any like established utility of all of these parameters in the emergency department. Also, like I guess like one of the reasons why we're not that advanced in diastolic measurements is because kids normally don't have as much diastolic dysfunction. But now with this increasing prevalence of obesity, hypertension, type 2 diabetes, I think it's very important to look at like how many like patients who are presenting with heart failure have that, and also like healthy patients have that underlying. But for me, I think it's like important. I'm very interested in congenital heart and I'm very interested in advanced, but it's also like person dependent how much they want to get their head in it.
Thank you so very much, Manaza. I think I understood like 15%, so I'm glad that this is recorded. It's recorded, so I'm going to go back and watch it again for like another 3 times. So it's going to be great. And so wanted to also, if you have not signed up for the CME yet, please take a look at the chat that Matt has included for the CME, including the activity code, and also check out our save to date, our little robot that we are recruiting for advertising for our P2 Network conference coming up in February 6th and 7th. It will be in Charleston, South Carolina next year, so please save the date for that. And with that, we're going to go ahead and move on to our next speaker. I'm happy to introduce Arti Sarwal. So Dr. Arti Sarwal is a professor in the Department of Neurology in the Division of Neurocritical Care at Virginia Commonwealth. And her interest is in cranial Doppler and ultrasound, and has published many papers and chapters where I met her from in some of our collaborative work in advanced ultrasound. And so please welcome Dr. Arti.
Can you guys hear me and see me all right?
Yes.
Yes?
Yes.
Oh, perfect. Thank you. Yeah, thank you so much, Dr. Tay. And it's such an honor to be amongst you guys and share what gives me butterflies in my brain, which is the brain ultrasound. And Dr. Ite asked me to focus on transcranial Doppler since it's the Doppler talk. And I can't thank enough my previous speakers for laying such a good groundwork on Doppler. So at least I don't have to cover that. And my hope is that in the next few minutes, 15, 20 minutes, I talk about just a very basic framework of how we incorporate transcranial Doppler in acute triage of patients. And I'm going to try and focus the content only on the pediatric ED indications. I'll talk to you about some very basic principles of TCD, correct probe placement, insonation technique. I'm going to assume that all of you guys really are familiar with the echocardiography. We'll be using the same probe here, just a few centimeters above the heart on the brain. And then we'll talk about waveform interpretation, and we'll focus the knowledge that we gather on a few core pediatric indications that you can actually take back to your ED and start using that. I will tell you a caveat. We typically do a 40-hour course over a week period to teach people TCDs. So this is like a very quick 15-minute primer, but I'll try to do my best to make it useful for you guys. So if you guys are like me, I'm a big fan of ultrasound, not because I think it's the ultimate tool, which I think it is, but because it really gives you a bedside perspective on so many physiological things. I think it's brought us back to the bedside in a way that EMR had taken us away. And ultrasound really both gives you the anatomy and the physiology, even for the brain. I always use this model of brain as a house. If you look at brain as a house, you look at the structure of the house. And when a patient comes with acute brain injury, you try to figure out what's wrong with the structure. Can I do structural imaging, CT scans and MRIs, of course. In children, we really try to avoid extra radiation exposure. So we got to be mindful. You can look at the plumbing of the house by looking at blood flow, whether you're looking at it from the invasive perspective or non-invasive perspective, which is transcranial Doppler. You can look at the electricity house with the EEG, too much electricity or not enough, and of course, serum and CSF biomarkers. Now, ultrasound can look at all these 4 components. Structurally, you can do B-mode ultrasound. That is actually part of my research called the CUPID study, cranial ultrasound for point-of-care intracranial pathology diagnoses. That's B-mode ultrasound. We will not be talking about that today. Midline shift, hydrocephalus, and ICH detection. I will be focusing on velocity measurements, cerebral perfusion measurement, and some measurements of the vascular bed resistance that actually formulates how you can use point of care ultrasound in emergency triage of patients suspected of acute brain injury. You can look at the other 2 components as well, but we will save that for another talk. So I'm going to use what we call as temporal windows as windows to the brain. And what you're doing here is you're taking the echo probe, the same probe you use for echocardiography, on the transcranial Doppler preset. Now, most, at least pediatric ICU machines, I have done a lot of TCDs. I have not done TCDs in pediatric ED. My hope is that they have a TCD preset. If you not end up having a TCD preset in your machines, you can always ask your vendor to create one. They should not be charging you more, especially for the most point of care machines. But if you still don't have it in one of the older machines, you can use the abdominal preset and you just switch off the THI. That will allow you some Doppler there. And what you will do is you will use the temporal bone just in front of your ears between the tragus and the lateral canthus. And this is where about 90% of the people have thin enough skull that it allows you to see through. And your index marker typically will be towards the eyes, which basically always puts the anterior to the left of the screen and posterior to the right of the screen. That's just a convention. So what we'll do is, in a child, you'll basically adjust the depth to the depth of the skull. In the adults, we say 13 to 15 centimeters. For the caveat, I am an adult neurologist. Most of my pediatric TCDs have been either investigational as a part of research, or sometimes I assist my pediatric neurology and pediatric ICU folks with that as well. So I'll try to make sure that I give you caveats where the knowledge is adult based. So if you adjust the depth to the adjust a little bit deeper than the skull, you will see the opposite skull. And then in the center, you will see this butterfly. And I hope you guys kind of can see this butterfly shaped structure. That's where the butterflies in the brain comes from. All of us have butterfly in our brains, and this butterfly is the top of the midbrain. This is your cerebral peduncles, and this is the back of your midbrain. And it kind of sits in this white fluff, and this white fluff is the subarachnoid space around it. And once you put on Doppler, you should be able to see the circle of Willis, and let's go a little bit deep into how to get these pictures. Now, as you see the orientation of this, remember, when I'm showing you ultrasound pictures, I'm showing you an axial section of the skull at the level of the midbrain, which is where the circle of Willis is. And this is what the circle of Willis looks like when we look at it. If you remember your neuroanatomy classes, for some of us that took years ago, or some of you guys who know how to look at CT angios, this is typically your ICA. This is your middle cerebral artery. This is your anterior cerebral artery, posterior cerebral artery, and then posterior circulation. We will focus this talk on the MCA because most of the point of care application that you will use MCA only. And this is typically what it looks like if this was the face, this was the back. If you rotate it 90 degrees, this is what the circle of Willis looks like. And when you hear me saying M1, M2, the proximal numbers, the smaller numbers are more proximal, the bigger numbers are more distal. M1 means closer to the midline, M2 means distal to the midline. So this is the orientation we'll be looking at, ipsilateral MCA, contralateral MCA. So this is what the skull looks like if you hold it against the light. In children, the skull is actually very thin compared to adults. In adults, the data is about 1 in 10 adults you can't see through the skull. But in children, that number is much less. And even for children that don't have acoustic windows through the skull like this, half of them will have acoustic window on one side. So never give up transcranial Doppler insonation until you've tried both sides. And we'll put the echo probe in front of the ears. It's always a good idea to start as close to the ear as possible and go window shopping, where you basically move your probe in circles until you hit the opposite skull. Then you know you landed on the window. The moment you land on the window, then you adjust your probe, either fan it or slide it so that you can see this butterfly in the brain, which is the skull. Now, it doesn't come across good in PowerPoints, but it really comes across when you do hands-on. You will start seeing pulsations here. And this is kind of a video of how we get the windows. We're moving the skull around. you're seeing this butterfly, and it doesn't come across, but you will start seeing pulsations here. Once you start seeing pulsations, you put on color. And the thing to remember here is circle of Willis is not a uniplanar structure. So you won't see the whole circle of Willis in one go. What you're seeing is the distal MCA trifurcating, and then around the midbrain, you're seeing the posterior cerebral artery. Now, in this particular case, PCA ends up being kind of the most common one, but I'm going to go ahead to the middle cerebral artery insonation. There. So here you can see the beautiful MCA. This is what I want you to focus on when you practice as a hands-on. Your MCA is directly going towards the probe, and you can see the bifurcation or trifurcation sometimes, and you adjust it to make sure that you can see as much MCA as possible. Once you see it, you will use pulse wave Doppler, not continuous Doppler. All vascular Doppler is classically pulse wave. You will make the depth, the sample of the pulse wave about 5 millimeters, because that's the width of the middle cerebral artery, 3 to 5 millimeters. And then you will put it either on the proximal or the distal MCA, depending on what you're interested in. And you start getting these beautiful waveforms. These waveforms look exactly like an arterial line waveform. And we'll talk about that in just a few minutes. So you basically get the butterfly, then you get the circle of Willis. This is your posterior cerebral artery. You're interested in the middle cerebral artery. Once you get there, you can sometimes get the whole MCA in one view. Sometimes you have to move up and down to get each segment. Classically, it takes about 15 minutes to insunate the whole circle of Willis, but for point of care, we'll focus on the middle cerebral artery. Now, this is what the middle cerebral artery looks like on the image. Your butterfly, your red going towards the probe is middle cerebral artery, and you can see the MCA-ACA junction, anterior cerebral artery is going away from the probe. That is your blue negative Doppler shift. In this particular case, the pulse Doppler is in the distal MCA, so we are calling it distal, 5 millimeter here, and then this is 1 cardiac cycle, 2 cardiac cycle, 3 cardiac cycles. Now, this picture I put in here just in case you don't have time or your patient does not have window on both sides. You can insunate the opposite MCA from the same side that has the acoustic window. Here you can see the midline across the midbrain, and then you can see the middle cerebral artery, but here it's going away from the probe. But the shape is very distinct. No other vessel can be confused with the middle cerebral artery here. The anterior cerebral artery here is going towards the probe, which is opposite of what you would see ipsilaterally.
Artie, so there's a question here.
Yes.
Rosemary. So if you're looking at anything in that region that looks prominent, will it be anything else other than the MCA?
No, there is only one single vessel that is so long and going towards the probe. Everything else is going to be deeper, and it's going to be anterior cerebral artery is going to be going away from the probe this side, and posterior cerebral arteries kind of wrapping around the midbrain. The only other things you will see are more superficial, about 2 to 3 millimeters close to the skull. But the best way to identify MCA and not mistake is make sure your midbrain is in the picture and it is right anterior and superior to it, longitudinally going towards the probe. It's very hard to miss and mistake with any other vessel. Great question. The only other vessel I do want you to be aware of is this anterior cerebral artery that basically kind of forms this V-shaped structure coming towards in the middle and joined by the ACOM. Sometimes it can be reversed. In children, if you see that, that basically means that there is collateralization, and I will talk about that in the stroke applications at the end of this talk. So let's look at this waveform and see the story this waveform tells you. Now, just like an A line, the initial third of it is systole, and the latter 2/3 is diastole, because that's the ratio between systole and diastole. And here you're looking at peak flow velocity at the peak of systole, and you're looking at the end diastolic velocity. These are the two velocities we're interested in that tell you the nature of this waveform with regards to resistance. But the number we're most interested in is kind of the map, the mean flow velocity, which is area under the curve. Now, the shape of the waveform is also very important. Here, you have a rapid upstroke. The brain likes to get all the blood. Stepwise deacceleration during late systole. Brain doesn't let go of the blood easy. Very slowly, throughout the diastole, brain keeps on holding on to some blood. At no point during this cardiac cycle is the blood flow going to zero. Keep that in mind when I talk about how this compares to peripheral circulation or high resistance circulation. Brain is a low resistance circuit because it's a vital organ. Body wants to feed it blood in the times of hypotension, shock, and inflammation, so it keeps the circuit low resistance. Now, this number called the mean flow velocity is the number we classically use, just like the maps we use in arterial blood line. Now, this map can be high because there is too much traffic, there is too much blood flow. That's hyperemia. This map is low if there is not enough traffic. There is hypoperfusion. Okay. Other times when this map can be high is spasm or stenosis because, say, a highway was 4 lanes and 2 lanes are closed. The traffic has to now move faster so that the traffic doesn't backlog. So high velocity is very sensitive, not very specific. It's very sensitive to say that either the traffic is too much or the traffic is moving faster through a smaller amount of lanes. Similarly, low velocity is very sensitive to tell you that there is low amount of traffic, the traffic is slow hypoperfusion, but it may also mean that you are looking at a waveform just distal to the area of high-grade stenosis. There was so much stenosis and traffic backlog that the cars are slowly speeding up, just like you see post-stenotic waveforms in aortic stenosis, parvus et tardus.
So
Now, what does this?
Are you
Yes.
going back to that? What is considered high and low, and is that dependent on age? Is it that like a child is different than an adult?
Very good question. That's exactly what the slide is going to cover. So in the adults, we have adult neurologists have 4 neurons in their head. So we can only remember 4 facts about stuff. I teach everybody double digits are good, triple digits are bad. That's for adults. I want you to remember that for full body weight adolescents, so about the age of 14, your velocities will start kind of following the adult value. For children, the velocities are different. The big picture is that very initially in the neonates, the velocity are lower than adults. And then between young children and late early adolescents, the velocity is actually much higher than adults. And they eventually taper off. And around 14 to 16 years is when they normalize. Now, pediatric neurologists love the z-scores and standard deviations. I don't know how pediatric ED folks are. So if you guys are similar, we are not smart enough to understand that. The Open Pediatrics has actually a calculator where these are the major hallmark studies, the 7 studies that have informed us normative criteria based on age. These are the characteristics of the study. And if you go to this Open Pediatrics links, it will actually give you age and sex. You can put the numbers you're getting, and it will tell you based on those numbers, based on the study, where the z-scores are for those normative values, and it will tell you if it's 2 standard deviations above or below. The caveat there to remember is in children, especially 3 years of age until about 14 years of age. So if you look here, triple digits are pretty normal, but they're never less than more than 200. So 140, 120 is pretty normal in a child between the age of 3 years and 15 years. But there are normative values for each age, as you can see here. In adults, as you approach 18 years, double digits is good, triple digits is bad. So this can give you some resources, and these are the 8 hallmark publications. You guys can decide which one represents your population the best. This data comes from pediatric ICU, which of course is not normative, but I put it here because if you're probably doing a TCD, it's a sick child. So I thought the ICU would be the most common normative values for you guys. So that was the traffic and the velocity. The second thing we can use TCD is this phenomena called resistance. All of you guys have managed patients with suspected high ICP. What truly happens in high ICP is there is increased distal cerebrovascular resistance. Blood flows through a vascular bed. If the ICP is normal, traffic is normal. If the ICP is very high, then there is so much resistance that it's backlogging the blood. So there is another number called the PI. What is this number? You heard about the resistivity index in the first talk. It's kind of similar, but the number here is peak minus end divided by mean. This number gives you an index of distal cerebrovascular resistance. In adults, the normal value is 1, plus minus 0.4 or 0.2, depending on the study you read. In children, after the age of 12, you will use adult values. Below the age of 12, 0.4 to 0.6 is the normal number. Again, the cutoffs for this have not been widely published, but 0.5, 0.6 in a single age child, 9 and below, anything above that would be considered abnormal. It is also very sensitive. It's very sensitive to say that you're supplying a distal cerebrovascular resistive bed, but it is not very specific. As you get older, your PI increases. So if I have a 75-year-old male, their PI may be 1.4 everywhere, and it may be normal. In a 12-year-old, that would be grossly abnormal. If I have a child that is 14 years of age and has renal artery stenosis and bad malignant hypertension for years, that has been very hard to control, non-adherent to medications, that child may have high resistance just from decreased compliance in the vessels universally. So it's a very sensitive marker. Serial changes are better than absolute values. So always take into context. If it's an otherwise healthy child and the first time you're seeing their values are 1.4, 1.5, that's abnormal. So high ICPs will cause high PIs, but so will distal atherosclerosis or other decreased compliance or increased resistive things that can affect the vessels. So low resistance is classical pattern for brain circulation, rapid upstroke, stepwise deacceleration, robust diastole, compared to rest of the body. Now, 5 vital organs, brain, heart, kidneys, liver and placenta have low resistance circulation, rest of the body high resistance. If you were to insufflate femoral artery or brachial artery, that's what you will see. Rapid upstroke, rapid downstroke. Late systolic reversal, barely any diastole, much less than third of the systole. That's high resistance. This pattern will be abnormal for the brain. If brain has this pattern, that means resistance is high. In your case, most common cause would be high ICP. Why the waveforms change the way they do, you'll have to delve a little bit deeper.
So, sorry, Arti, there's like another question from the previous slide.
Yes.
Can you go through how mean and PI are different? Because
Good.
both are measuring both peak systole and diastole.
Very good question. So between this waveform and this form, PI will change dramatically. And I will show you a few case studies in a few minutes. So from here, this PI is probably say 0.6, 0.7. This PI is probably 2.1, 2.2. Now the mean flow velocity is a tricky question to ask because the mean flow velocity here may be say, 90. The mean flow velocity here may stay 90 initially, but as the diastole goes down further, this is why we always take end diastole, the mean flow will eventually drop. And those patterns are serial changes are a little bit different than just one absolute number. And that's what I was trying to say here. Spencer-Reid curve is the curve. You'll have to go a little bit deeper. And I can cover this in an advanced talk if you guys are interested in neuro ultrasound. Initially, mean flow velocity will stay the same. PI will slightly increase. But when the PI goes to the peak with the diastole almost zero, then the mean flow velocity will start dropping. So great question. So this is a low resistance waveform, rapid upstroke, stepwise deacceleration, robust diastole, and diastole is at least a third of the peak systole. You can see the PI is relatively normal, at least for an adult. For a child, the PI of 0.6, 0.7 might be normal. This is high resistance. You can see how diastolic component is so low compared to the peak systolic. So ballparking, you can see the difference. Absolute numbers, of course, you can calculate as you can see here as well. Now, two things. One is focal increase in resistance. If you're seeing a patient with stroke, you only have intramural thrombosis or intracranial stenosis, which in children can have microangiopathies. There, this high resistance pattern will only come as you approach the stenotic area. And as you go beyond the stenotic area, it will actually have parvus retardus waveform, just like your aortic stenosis patients. That's focal decrease. In lumen, focal increase in resistance. If there's global increase in resistance, every single vessel, right and left, will have high resistance waveforms. And if the ICP goes higher than your systemic diastolic pressure, you can actually get oscillating waveforms. During systole, blood flow goes to the brain. During diastole, it goes opposite. Eventually, systolic stumps and no flow. That's the march of death that we call as cerebral circulatory arrest. Now, how do I apply it? That's the last part of the talk. Real case studies of where I would use this information. You have a child with disorders of consciousness, GCS of 3 found down, looks hemodynamically stable. You don't have any history. You're trying to triage the patient. And as you're triaging, heart is fine. The brain has normal waveforms, normal resistance, normal velocities throughout for age. That's a brain that at this point is happy. You can prioritize other things and you can decide your priority based on the patient's presentation. Compared to this brain, say you were looking at the brain and you told your fellow or your resident, hey, come, I learned this neuro ultrasound. And then they come back 20 minutes later. Oh my goodness, the diastole is lower. And then he brings another medical student to say, hey, let me show you what the brain MCA looks like on ultrasound. And look here, oscillating waveforms. You can safely say that between the first and the third waveform, the patient's ICP has increased dramatically to the higher than patient's diastolic pressure. So if this was present throughout bilaterally, you know the global resistance has increased and the patient is having ICP crises. Based on the presentation and clinical context, you can decide what to escalate, MAPS, or ICP management strategies based on the presentation. Another example. This was more of a pediatric ICU example, but just to give you a perspective. My understanding is in pediatrics, we still use high frequency oscillators for some ARDS patients. This was a patient that even an ICP monitor was not giving us waveforms because of the EVD vibrations produced by the high frequency oscillator. We were still able to get TCD waveforms despite these artifacts. Enough to say that this is high resistance waveforms, and this is a child that needs ICP lowering strategies. We also used midline shift assessment on B mode ultrasound, which I have not covered in this talk, to basically say this patient has high ICPs. And when we were able to get a CT scan, that actually came out to be true. Patient had an ICH and cerebral edema around it. Another case, a very common brain death mimic. We had a patient that basically had no brainstem reflexes. We could not get a CT scan because the patient was on ECMO for Wellbutrin overdose causing vasoplegic shock. And we were asked to basically, there was an ethical concern, and we were asked to corroborate whether the patient is brain death or not. Now, I will give you the caveat, TCD is not an approved study for brain death in children, but look at these blood flow patterns. Can you tell me that this patient has normal blood flow patterns? They're a little low on resistance, but for a VECMO circuit, that's very good flow, good velocities throughout. Does this patient have cerebral circulatory arrest? No. So I was able to use this TCD to say this patient does not have cerebral circulatory arrest, and you'll have to use other. So we kept on resuscitating the patient for 2 more weeks, and the child actually recovered with minimal cognitive deficits. So we use this to rule out brain death. Another way, this is an adult case, but I will tell you how encouraged I was to find literature in pediatrics when I was preparing this talk. So this is a patient that is being triaged and managed for cardiogenic shock because of a ruptured aortic aneurysm and had already gotten a balloon pump intraoperatively and was getting Impella. And we were asked to give prognostication. And this is a patient with balloon pump and Impella, 2:1 waveforms for people who are familiar with MCS. Look at the amount of vasopressors this patient is on. For an ECMO patient, there is not a bad blood pressure, but look at the cerebral waveforms. I have very commonly seen good diastolic flow. Good diastolic flow is important for brain health. This is a patient that has oscillating waveforms. You can resuscitate the patient till the cows come home, the brain's gone. So of course, 6 hours later, patient blew the pupils. Patient's CT scan showed malignant cerebral edema, and she was declared brain death later during the daytime.
RT, and I humbly ask, what is Impella?
Impella is a form of mechanical circulatory support where you basically put a catheter inside the left ventricle to help it pump. ECMO, Impella, ECPella are all forms of mechanical circulatory support. People with eCPR use it. It's not a very commonly known support unless you are in an eCPR program.
Thank you.
Thank you for asking that. So I was actually able to find a very nice case report that showed that the transition of these waveforms where diastole was lost actually preceded a patient having code blue by quite some time. So that gave me a very encouraging reason why TCDs can be important in resuscitation of an unstable patient. That patient lost diastole before the systemic collapsed. This was a post-op patient. Now in post-cardiac arrest, at least in the adults, this is my last 4 slides. We actually have information which is phenotyping patients differentially. And I thought this was in adults, but there was actually a pediatric study that used this to target different therapies for post-cardiac arrest patients. So these waveforms are hyperemic. The diastole is very high compared to the systole, almost the same. This is a high resistance waveforms. Hopefully you guys can distinguish these two. And either of these waveforms are bad. If it's hyperemic, these patients develop delayed cerebral edema. If these are resistive waveforms, the horses are already out of the barn. Patients are having ICP crises. In hypoxic arrest or anoxic arrest, that's a bad sign. In pediatric study, this study actually used these waveforms to categorize patients into 3 phenotypes: hyperemia and resistive waveforms and normal waveforms. And they actually created a stepwise algorithm to either increase blood pressure or to institute ICP loading management, and showed that when you use TCD guided resuscitation, you actually had better 1-month survival compared to no TCD guided resuscitation. And I hope to do this study in adults soon, but this was very encouraging to me. Lastly, the
Okay.
use of Yes.
I'm sorry, one question. To keep interrupting. Can you intervene at oscillating waveforms to decrease resistance and prevent brain death? That's the question.
Yes. In pediatrics, I would wholly say yes, and I have a slide to that coming up soon. So oscillating waveforms in children should never be taken as irreversible brain injury. They should be taken as a goal to either increase MAPS or institute ICP lowering therapies, because in children, they're more often reversible than adults. And this is exactly what this study did. It increased osmotic agents, it gave volume bolus and vasoactive agents until the diastole was restored to be positive. So it can actually act as a goal-directed therapy here. So great question. So stroke, I will reserve this because that has some nuances where you have to understand the focal resistance and the Parvus-Dardas changes a little bit more. Sickle cell is not a pediatric ED complication to diagnose, but one of the hallmark complications. The only thing I would ask you to notice, if you're doing TCDs and you see this spikes, almost bird chirps coming on, that's a patient actively having embolic hits. That's emboli going to the brain. TCD is the only dynamic study that can show you that. So don't ignore that finding. Find somebody who can explain to you why the patient is having embolic strokes. So the last slide is putting it all together. I hope that these waveforms gave you a little teaser, but no way this is an exhaustive talk, that hyperemic, normal resistance, high resistance, and oscillating waveforms gives you a ballpark to understand a patient with disorders of consciousness. When you have unknown etiology, you can use that as a surrogate for cerebral perfusion. If you have a patient with suspected cerebral edema, you can use it to screen out and screen in presence of malignant cerebral edema. And not just that, you can complement it with existing neuroimaging to serve as a goal-directed therapy. With this waveform, you should be increasing blood pressure and giving osmotics or any other ICP loading management until diastole is restored. And that's actually goal-directed therapy. In ischemic stroke, don't forget to look at emboli if you actually see them. Don't ignore them. This is the only physiological study that will look at that. Last caveat, as I fold this talk, please do not use oscillating waveforms or systolic stumps or absence of diastole to declare brain dead. TCD at this point is not approved for brain death declaration in pediatric children, but please use this to escalate therapy in adults. Two waveforms like these in everywhere globally are considered irreversible when done 30 minutes apart. In children, that's not true. Children have more compliant skulls. They actually tolerate this much more often. Kerry Laver actually shows a case that this waveform reversed after 18 hours. Patients still survived. So please use this as to escalate your therapies. I will leave you some resources. These are some pediatric ICU applications, a very nice multidisciplinary consensus statement left over for your reading. So waveforms will tell you a story. You just have to know the story. And there was a pediatric neurosonology symposium we recently did. I just posted all the YouTube videos. They're free to watch. You can use this QR code to access it. Some more fine applications. And I hope that you guys will consider incorporating neuro ultrasound in your resuscitation algorithms and consider learning more about it and find as much joy as I in incorporating it into in my brain resuscitation algorithms.
Thank you so much, Artie. That was a wonderful talk and a really great introduction for some of the applications that I'm sure that a lot of us have not encountered before, but thank you so much. I'm going to turn it over to Matt. Oh, does anybody else have any questions? Any other questions before we turn over? Okay, great. Thank you. Matt?
Hey, all right. So we are going to move on from our presentations to our cool cases. We got a number of submissions and ultimately could only fit in 3 presentations for our webinar today. We would like to first ask Dr. Silva to present. Dr. Silva, if you could pull up your slides and share. Dr. Silva is faculty at Baylor. He is the director of the ultrasound fellowship there at Texas Children's, and he is going to be presenting the first of our 3 cases.
Thanks, Matt. Getting my portion of screen set up here. Let's see if this works. Oh, that's going to be a bear. I'll just take my alternative method here. We've switched over to Teams, so I've neglected my Zoom skills for a while. All right, awesome. So these should be my slides. and assuming everyone can hear, thank you guys for the opportunity to share this interesting and surprising case with y'all. Well, I'll let it speak for itself. We struggled to find a witty and professional title given the area of interest for this patient, so we settled on seeing red and blue. We're going to use color Doppler assessment of scrotal swelling. Dr. Manley is one of our PEM fellows and just won our Smooth Operator Award last year, which means he was the physician in our division that performed the most ultrasounds. Obviously, our POCUS faculty excluded, so he was happy to pick up the probe in this case. So we had an 11-month-old male that was referred from an outside facility. Parents noted that in his diaper region, specifically on his scrotum, there was this erythematous kind of lesion that they said had maybe tripled in size over the last 5 days. I wasn't sure if I could share the actual picture, so you're gonna have to imagine with me here. We found this to be erythematous and agreed. We also thought maybe there was a little bit of discoloration, kind of this yellowish discoloration there at the inferior pole of the lesion itself. It was probably about 2 centimeters right on the midline of the scrotum. He was afebrile, didn't particularly seem to bother him during examination or during diaper changes that parents reported to us. So we started with our B mode images, and just to orient y'all to where we're at here, I've put some ovals around the particular lesion, and we'll let these clips play and show you. We can see, especially from the transverse view, that this looks to involve the skin. Doesn't appear to be inside the scrotum, part of or one of the testicles itself. We didn't see any, reactive hydrocele or anything to suggest that this was something happening within the scrotum itself. And so we were happily proceeding along to our expected diagnosis and our expected plan involving probably a scalpel. And we thought, well, let's get some, look for the squish or swirl sign, whatever you call it in your shop, looking with compression to expect to see some fluid moving around within the lesion. And you can kind of see that doesn't really happen. This lesion more so displaces the tissue around it. This was, when your brain kind of detects something's wrong, but you don't give it much thought. And so I had this little red flag in my mind go off thinking, okay, well, that's interesting that I don't really see a lot of, swirling going on in there. But Dr. Amanli very astutely turned on the color Doppler. Our machine has just color as the button. And as Dr. Al-Sharif said earlier, we want to know, does this thing have flow? So it did, and had a lot of it. We really glad I had my mask on. I wasn't expecting this, and glad the moms couldn't see my jaw just about hit the floor on this one. We might have expected some peripheral kind of, hyperemia, flow, vascularity around a fluid collection. And of course, we didn't expect a lymph node on the midline of the scrotum. So we were quite surprised to see A, flow within our lesion, and B, this much flow happening. So we decided to abandon our hopes for potential incision and drainage and definitely consult urology, who had requested a radiology ultrasound to add although I will say they did add a little bit of a differential diagnosis, one of which included an epidermoid cyst, which seems to maybe make sense. Apparently those can become acutely inflamed, which might explain kind of the perceived growth or probably true, kind of growth and at least an inflammation and surrounding erythema on this lesion. And they did measure at about 1.9 to 1.98 centimeters. So otherwise, unfortunately, the patient has not followed up with urology. Might have something to do with the fact that they live 3 hours away from us, but we don't have a resolution for you guys. But I did want to focus on some pearls here. If you're seeing red, you're seeing something that looks like acute inflammation. Certainly, if you think it's an abscess, it's just, too easy, assuming you've got, a focus machine and somebody who's trained to use it, to grab the probe, even if you're not going to use it for your static guidance, just to make sure you know what you're going for. And I will consistently recommend adding in some blue, right? So, I think consistency is key in soft tissue focus. We had a worksheet that included color Doppler when I started, and I just kind of ended up using most of that just because it was an item on our worksheet, using it in most of my studies. And I think after this case, especially, I'll be consistent with it. It takes the time, our clips are 6 seconds long, right? So the time to add 2, 3, 4 clips at most additional to your study, and can certainly make a difference for a patient or you if you're thinking about putting a scalpel in something that could end up being a disaster. Thank you.
Thank you, Dr. Silva. We're going to go through all of the cases and then open the floor to questions to all three of our presenters. Next is going to be Dr. Chantel Johnson. She is a Penn Fellow at Yale and will hopefully, with your encouragement, be a future POCUS Fellow in 2 years.
Just give me a head nod, Dr. Kasoulis, if you can hear me and see my screen. Perfect. So I'd like you all to go on a journey with me. So to set the scene, this is where I work. Yale is the best place on earth. And as the sign says, heroes work here. And just for context, this is actually our website. And the point of this slide is that we're always open. So it was just another typical Friday in the ED. It was nice and quiet. Just kidding, our ER never looks like this. And I used the Q word, so truly it looked like this. And it was a Friday, so it soon turned into this. But let's focus on our patients. We're going to focus on little Timmy in the back. So we had a 9-year-old boy who was riding his bicycle without a helmet. He fell over and landed on his right-hand side. He reported that at the time he had 15 out of 10 pain to his right knee, his groin, his thigh, which had improved by the time he presented to our ER. And even though he remembers the entire event, he said it happened really quickly, so the details are a little fuzzy, but he thinks that the handlebar hit his leg. He denies head strike or loss of consciousness. On physical exam, his vitals were normal, his GU exam was normal, cremasteric reflex intact, his right knee, full range of motion, where he said he had previously had pain, but was non-tender. But then we rolled up his shorts and we discovered a right proximal inner thigh swelling with bruising, but it was small and per report was not changing in size at all. It was mildly tender. He had some pain with hip flexion, but otherwise was able to move his extremity well. But again, just remembering and keeping in mind, it's a full ER, so I'm still seeing a lot of patients, critically ill patients, trauma patients, and throughout my entire shift, this is all that I hear. But because I remember that heroes work here and I have to channel my inner hero, I revisit the room. So when I initially saw this patient, it was just him and one caretaker. Now the room was full of eyes staring back at me. I went over the story one more time, and this time Nana's in the room and is adamant that the lesion is expanding and getting bigger. So now I have no choice. I truly have to do a POCUS and we can't wait. So I had the patient position himself in what was most comfortable for him, put a lot of gel to decrease pain, used my linear probe, and took a look at the lesion in my MSK superficial setting. For my clinical question, I just wanted to know, was this just edema, hematoma, maybe a pseudoaneurysm? And also I wanted to know the proximity to any vasculature. So first, I just took a look at the lesion itself. Here, I wasn't sure exactly what I was looking at, maybe a lymph node, maybe hematoma, maybe pseudoaneurysm given the history. So then I just scanned through the entire lesion. Just going through my anatomy, I saw my epidermis. I do see some edema here, which is depicted by our cobblestone patterns. We see these anechoic irregular channels of fluid. And adjacent to my lesion, I see a large vessel. This is just a still of the video, just for a more detailed look at what my area of interest was. And I still wasn't 100% sure. So when in doubt, what do? I asked the P2 network. So this was a talk done by the great Dr. Julie Leviter, and she talked about the lymph nodes in the inguinal region. And so we know that typical lymph node pattern, round or oval, clearly demarcated, has a hyperechoic hilum within the node, and some vascularity. So what we thought we were looking at here is two lymph nodes. We see that we have these two round structures. We see our hyperechoic hilum, well-defined, smooth borders, and then this intersection, which was anechoic, we think it was our hematoma. And then to better characterize the lesion, put flow on it. And here we see normal lymph node flow. Don't see a yin-yang sign or other patterns consistent with pseudoaneurysm, which is what we were concerned about. You see the bidirectional flow, which is the arterial inflow and venous outflow along the hilum axis. It does seem a little hyperemic to me, but this could be secondary to inflammation in response to trauma. My flow velocity is also set to 2.5, so highly sensitive as well. So that could be blurring the picture somewhat. So I have a structure, likely two reactive lymph nodes, hematoma, might be expanding close to large vasculature. So we got on the phone and talked to the ultrasound tech to see if we could expedite a radiology performed ultrasound. And so their images looked very similar to our POCUS. You see the two lymph nodes, the hematoma. And when they did their ultrasound, they also looked proximally and around the area of interest and found this on their ultrasound on their fancy machines. And so they saw this communicating channel from the right common femoral artery into that same lymph node hematoma space. And this is the pulse wave Doppler from that same extravasation. It showed arterial waveforms within the collection as well as in the channel. And so their final impression was that there was in fact extravasation from the common femoral artery. The general surgical team and vascular surgical teams were consulted, and then a compression dressing was placed and the patient was admitted to the hospital. So the next day they did a repeat ultrasound, and this is what it looked like. So the hematoma had mostly resolved and they only saw the lymph nodes, and clinically the patient looked much better. And the following day after discharge, vascular surgery followed up with this patient, and the hematoma was fully resolved and the patient was doing great clinically. So some of my takeaway points, that's my 2 cents. It's important to be able to recognize normal lymph node architecture. Remember to scan beyond your areas of interest and explore the surrounding structures. And Doppler can aid in your identification of different structures. And bedside ultrasound can expedite your management even when you don't have all the answers. Thank you so much.
Thank you. And our last speaker, where did I put it? Dr. Lee, do you want to pull it up? I'm just trying to find what I wrote to say about you.
Sounds good.
Dr. Lee is a resident at the University, resident at the University of...
Wait, I'm a fellow.
Oh, sorry. I'm a fellow at the University of Pittsburgh, and she's presenting the third of our cases. Go ahead,
Dr.
share.
Johnson, is it okay if you stop sharing your screen? It won't let me
Oh,
share.
there you go.
Yeah, thank you. All right. Are you guys able to see my screen?
Yep.
Perfect. Awesome. Nice to meet you guys. I'm Ji Young. I'm a pediatric emergency medicine fellow at the Children's Hospital of Pittsburgh. And today we are going to talk about a bloody surprise. So, a 15-year-old female presented to the emergency department with swelling and some bleeding to the bottom of her foot. 2 weeks ago, she had stepped on glass that was removed well and had been doing okay. And 2 weeks later, she was noticing this swelling that was coming to be more obvious. There was no discharge, there was no induration, there was no streaking around it. She didn't have any fevers or any other systemic symptoms, but she said, it's swelling up more and it's just bothersome when I walk. So, as every good PEM doctor would do, we looked at it together and tried to see if anything was coming out. Nothing was coming out at the moment. And so we put a POCUS probe on it, and it showed this on the B mode using a linear probe. There was a little bit of soft tissue swelling, but not significantly. There's not a ton of cobblestoning. And we saw on this one cut like a little bit of the circular structure that is pretty superficial and about that had a puff of smoke sign in the middle. And as you can tell, almost looked like it was maybe potentially could be pulsatile. And so we got it from another angle, it's perpendicular, and it showed this. And I think a lot of us would feel a little bit of hesitation going after this and trying to figure out what this is. And so to get a little bit of, and as you can tell, it's very round, very circular, without a lot of irregularities. And like I said, not a lot of like cobblestoning around it. That would be concerning more for an infection. And so we put some color Doppler on it, and this is what it showed. The nice yin and yang sign that Dr. Johnson had mentioned earlier. And so we discussed this case with our surgery colleagues and showed them the image. But given that the patient was still really uncomfortable, despite the findings, they decided to perform a bedside IND. There was pulsatile blood flow hitting the wall, and the patient lost a lot of blood, actually requiring a transfusion. And she was diagnosed with a post-traumatic arterial pseudoaneurysm. So a couple of take-home points, recognizing that a pseudoaneurysm formation following penetrating trauma could be the cause of swelling, especially in the foot where you have the medial and lateral plantar arteries. And Doppler ultrasound is super helpful for differentiating vascular lesions from abscesses or soft tissue infections. Thank you.
Dr. Lee, I don't know if I would actually jab that myself. Like, given that, like, what were they expecting? Like, did they?
Yeah, so I think that's why our PEM colleagues were hesitant to go after it as well. But I think they were kind of curious what was there. And just given that it was a delayed presentation, the patient was having a lot of discomfort. It was a shared decision making with the family to try to see if that would relieve it a little bit. Ultimately, they were able to ligate the artery once they did it. And then the patient did well and was discharged home the next day after a blood transfusion.
Oh, after a blood transfusion. Oh, wow. Yeah, no.
Are there any other questions or comments for our three case presenters? All right. Well, thank you all for joining us for our fall webinar. If you haven't noticed, we've been throwing the save the date for our upcoming conference in Charleston. We hope to have registration details available to people by the end of November. So that'll give everybody 2 months to get their registration in. The agenda should be available at that point as well. We will be sending out a general teaser agenda in the next day or so, so keep an eye out for that. In the meantime, if you can take the 3 minutes to fill out the CME questionnaire that'll give us some information and feedback about today, as well as give you CME credit. I threw that back into the chat for you all as well. It's also on the link in the P2 newsletter under agenda. Thank you all for being here. Thank you for all to all our presenters and case presenters. We'll see you in Charleston.
Matt, you want to stay on for 1 second?
Of course. Let's stop recording.
Yeah.
Where's the record? Pause stop.